going to be discussing gingival grafting when there's inadequate keratinized or attached gingiva. In this particular case, you can see that the non-keratinized unattached gingiva extends to the gingival crest, as evidenced by the mobility of the tissue. Now you'll remember that the keratinized or attached gingiva serves as a hard rubber band around the neck of the tooth to keep bacteria from going down the root of the tooth and causing bone loss. If you don't have adequate keratinized / attached gingiva, then there's nothing to block the bacteria from going down the root of the tooth, and ultimately many people in these situations will lose the teeth. So we always want adequate keratinized or attached gingiva around the neck of a tooth. How much is adequate? Generally, it's thought that you need at least a couple of millimeters of attached keratinized gingiva around the neck of a tooth, keep the bacteria from going down the root of the tooth. So I'm making an incision in the tissue, not quite to the crest of gingiva or the gingiva line. That way it's easier to suture and this part won't pull out. This is a very difficult area to suture because of the pull of the chin and the lip, and many times this will come open. There's another procedure called tunneling, in which you leave these different attachments and just make some holes and press the grafting material in between the holes, and it helps keep this wound or this incision from opening up during healing. If it does open up, it's not the end of the world, but sometimes you've got to resuture it after a week. This is a split thickness flap. What does that mean? It means I'm not reflecting all the way to the bone. I'm trying to keep the periosteum on the bone so that there's blood supply from the bottom and the top of the tissue pressed up against the graft. So this is very lightly just filleting that tissue and leaving all or most of the periosteum on the bone and just reflecting the tissue facial to that. Now this is the perioderm. Perioderm is human allograft skin minimally processed to remove epidermal and dermal cells. The process utilized preserves the extracellular matrix of the dermis. The resulting allograft serves as a framework to support cellular repopulation and vascularization at the surgical site. In other words, a pseudo-keratinized attached gingiva is created. Now, when you're placing the perioderm, you'd like the epidermal side to be facial. And the way you can determine that is a couple of different ways. Number one, there's a little notch in the perioderm, and you always keep that to the left when placing the perioderm, and that will ensure the epidermal side is on the correct side. You want the dermal side toward the bone and the epidermal side away from the bone. Now some surgeons, some people say it doesn't really matter, but it's just as easy to do it this way as the other way. The dermal side, the epidermal side may have more pigmentation than the dermal side. For further verification, add a drop of blood to both sides of the graft. Then rinse with sterile saline. The dermal side will appear red and the epidermal side will appear pink. That makes sense because the epidermal side is a little denser and you're not going to get as much absorption of the blood. Now, hydration occurs by placing the perioderm in sterile saline for about 5 or 10 minutes. When I'm doing these procedures, before I begin, I go ahead and put the perioderm in a dappen dish of sterile saline and just let it soak, and so it's probably going to soak for 15-20 minutes. It probably only takes about 5 to 10 minutes for it to rehydrate. But just go ahead and put it in there because you can't overhydrate it. And once you do hydrate it, you can see it's very flexible. It's not rigid at all. So I'm placing it in the graft site and then trimming it. So the epidermal side is out and the dermal side is toward the bone. Then this is 4-0 plain gut suture, and I'm suturing through the tissue and through the coronal aspect of the graft. And I'm going all the way through the papilla to the lingual side. Now, as you can see, this is pre-restorative treatment. We're going to restore these teeth after we establish the attached keratinized gingiva. Through the tissue on the facial, through the coronal part of the graft, through the papilla. Now, when you come back through, you don't have to suture through the papilla coming back this way. Just go through the, see, I'm just putting that through the opening there. But I do engage the papilla on the lingual side. 4-0 gut suture will resorb in 4 to 7 days. Now, if you need a longer lasting suture, you can use chromic gut, and it will dissolve in about 2 weeks. You're going to encourage the patient not to have a lot of lip or chin movement, not to flex their chin, or they'll definitely pull this loose. Now, you can see this is all unattached gingiva right here, and it looks very flimsy. Now, just a reminder not to move her chin or lip very much. I'm going to place this compression bandage on the chin, and she'll leave that on there until the following day. And so initially it's going to keep her from doing that, especially if she's been sedated and she's not focused. Now here you can see after 1 month of healing, we've got nice dense tissue here. And so we're ready for our restorative dentistry.
Thank y'all so much for joining us on this week's episode of the Dental Minute. Go ahead and subscribe right now, right here, and get excited because next week we are talking about how to perform a deep cleaning. Everyone needs to know how to do this. We'll see you next week.